My name's Dr. Sara Ajina. I'm a clinician scientist at UCL, and I'm going to talk to you about the neuroimaging markers to predict visual rehabilitation outcome in hemianopia. Now, acquired brain injury can include stroke and traumatic brain injury, and when it includes the primary visual cortex or its underlying pathway, then it can cause hemianopia. And hemianopia is a loss of vision on the opposite side of space to the side of the lesion in the brain, and it can cause difficulty with reading, navigating, with driving, and it impacts negatively on quality of life. And visual loss such as hemianopia is actually very common after an acquired brain injury, with the prevalence in the UK compared to MS here in order to give it some context. So it affects millions of people worldwide, and actually there are no clinical interventions currently available to recover vision. Now this is a schematic of the primary visual pathway shown in red. Information from the temporal fields of both eyes cross in the optic chiasm such that the left side of space in front of you is transmitted to the right side of the brain and vice versa. And signals are relayed via the M and P layers in the LGN and then via the optic radiation to the primary visual cortex or V1 and other visual and non-visual areas in the brain. Now research in the last few decades, in particular that I've been interested in, has suggested that there may be additional primary shortcut visual pathways that can also carry visual signals and can influence visually guided behaviours in individuals who have damage to the primary visual cortex, so-called blind sight or residual vision, which may be a preferable term. And over the last 12 years, we've run a number of psychophysical and neuroimaging experiments with patients with V1 damage. And our hypothesis that's particularly relevant in this talk is that shortcut circuits that mediate residual vision or blind sight can also be targets for recovery training. But we need to understand the properties of these pathways in order to design optimal interventions to drive recovery and plasticity, and to predict who may benefit most from which types of treatment in patients. And in this slide, we can see a stimulus here in the centre, which is particularly salient to blind sight. And at high contrast, it can be detected significantly above chance, but it's also associated with greater confidence of having seen something in the blind field. And we started with visual evoked bold response, very simply demonstrating where in the brain weak responses were evoked by images in the blind field of patients. And we used both Gabor patches, as shown here, and moving dots. And importantly, we also altered different parameters of the stimuli in both the blind and sighted visual fields in order to measure how activity changes in different regions in the brain. And this showed us that MT actually changes its response pattern after primary visual cortex damage, which is likely to reflect its residual innervation. And it's basically now behaving much more like an early visual cortex area. And that's true for both stimuli types. We then applied diffusion, MRI and tractography in our patients, and this time with a slightly larger participant group of 17, 12 of whom demonstrated blind sight for high contrast drifting Gabor, and 5 of whom did not. And we compared the properties, including fractional anisotropy and mean diffusivity, along both the primary visual pathway and the supposed short circuit pathways, in order to see if we could uncover key differences between these two participant groups. And of the pathways that we looked at, we found that the LGN-MT tract had substantially lower fractional anisotropy in blind sight negative patients. Now, diffusion tractography has its limitations, which I'll come to later. But another tool to compare neural connectivity in patients is functional connectivity, either using resting state or, as we've also done, using an fMRI time series from visual evoked activation and then regressing out task response in order to compare residual time series in our regions of interest. And this is very complementary to our diffusion work. And we showed that LGN and MT had also lost their functional connectivity in blindsight negative patients, whilst connectivity with the pulvinar and superior colliculus was retained in that patient group. And we now have a cohort of patients, which we've gathered over the last few years, which is appreciable in size. And this allows us to use correlation-based tools, such as voxel-based lesion symptom mapping, based on different behavioural measures of residual vision, and the structural scans of 40 participants with hemianopia. And initially, we looked at using Eulick-defined visual areas, as shown here. And then applying voxel-based lesion symptom mapping approach. And we were able to show that contrast detection in the blind field correlates inversely with the proportion of damage in MT. And from a voxel-based analysis, we can see clearly an association between performance and the optic radiation close to the MT region. So we're now going to apply all of this to rehab, and I'm going to show you some data from what was essentially a pilot project with a small number of participants, so 7 participants, in collaboration with Professor Arash Sari from the University of Aberdeen, who developed a Gabor-based visual training program for patients. So participants undertook at least 3 months of visual training at home for 30 minutes 5 times a week on apparatus similar to depicted schematically here. And we measured a number of visual domains pre and post training, which includes contrast detection, using a stimulus that was similar to that was used in training, although not identical. We also measured patients' ability to detect moving dots and to discriminate direction of motion, and clinical static perimetry before and after training. And actually all participants showed some improvement in at least one of the visual domains that we tested. And there are 3 main findings that I'm going to highlight from our fMRI results. So first of all, looking at baseline predictors of change, so baseline levels that were associated with our clinical and psychophysical change results. So of note, it was pre-training bold signal change in V5 that was associated with change in contrast detection. And in particular, was associated with a change in clinical perimetry at the trained region of vision. Now, we were also interested in just how responses changed pre and post training. And what we found was that responses were boosted after training in V5 for stimuli shown to the blind field, which was true for all but one of our participants. Now, a surprising finding, however, for us was actually that visual evoked responses in the sighted field also changed. So in fact, there's been a reduction in ipsilateral activity. So in MT in the damaged hemisphere, when images are shown to the sighted field, those responses are reduced after training. And it's actually only recently that we've put this together with an old finding that we noticed some years ago, that patients actually tend to show greater ipsilateral responses to images in the sighted field compared to healthy controls. So that's actually led us to think about a new hypothesis, that it's possible that after primary visual cortex damage, the MT may maladaptively be recruited for the sighted field. And it's possible that we may need to try and reduce this imbalance in order to re-recruit the residual visual pathways in the damaged hemisphere. So we then looked at connectivity specifically, both using fMRI and diffusion MRI. And to start with, we wanted to see if there were any changes in connectivity pre and post training. So using fMRI, we could see that there was a weak boost in connectivity between LGN and MT, and to a lesser extent LGN and V1, and pulvinar and MT. And of note, just to continue with our kind of our ipsilateral finding that I've just mentioned, we also checked to see if there was a change in connectivity between LGN in the intact hemisphere and MT in the damaged hemisphere. And we found that there was in fact a small reduction in connectivity that would fit with our previous observation. We then looked at diffusion tractography, shown here on the right. So these three profiles are the mean profiles for all participants, normalized according to the length of the streamlines. Actually, just looking at these panels, so we've got pre-training, which is shown in red, and post-training is in blue. But actually, there's notably lack of difference really here in terms of the track profiles comparing pre and post training. That's true for FA, shown here, as well as MD. But actually, there's a limitation with the diffusion MRI, which in a way we've been plagued with since we started using it in our patients. And that's the issue of overlapping pathways in the optic radiation, and the fact that LGN to V1 or to MT or pulvinar to MT actually all share a large chunk of overlapping streamlines when you run tractography. And there are various ways to try and tackle that. In our previous paper in eLife, we looked at just the distal portion of the tract to MT, which sort of deviated away from the bulk of the optic radiation pathway as a way of getting a separate measure. And here I tried to create basically forced streamlines, shown in the bottom panel, to V1 in the damaged hemisphere, and then created a thresholded binary mask, and then used that to clip the streamlines to MT. And that showed a difference in between basically the early now and the later parts of this tract profile than we could appreciate before. And so now we're seeing more clearly that in the beginning of the pathway towards the LGN, that post-training there is a definite increase in the fractional anisotropy, which was true for all of the participants, whilst in the distal portion of the tract, we see fractional anisotropy dropping off again in all our participants. And the last and really primary outcome in this study was to look at baseline measures of connectivity and to compare how they correlate with behavioural changes with training. And I've illustrated here three of the key tracts of interest, again using both fMRI in the top panel and diffusion MRI connectivity at the bottom. And although we did look at other pathways as well, which includes interhemispheric connections, so not only between LGN and MT, but between MT bilaterally, as well as direct tracks involving the superior colliculus. But we focus just on this slide here on looking at LGN to V1, shown here in red, LGN to MT in blue, and pulvinar to MT in purple. And so the V1 pathways where it can actually detect something. So in the fMRI connectivity, we actually saw, you can see that there is some difference in terms of the baseline connectivity. And actually of our participant group, 2 participants were basically at 0 because their lesions were such that there was no residual primary visual cortex at all, in order to show residual connectivity with the LGN. And we're interested in looking at this pathway because not all patients with hemianopia will necessarily have the whole of V1 damaged, and there's certainly a plausible and viable possibility that if there is a preserved primary visual cortex and connectivity to the primary visual cortex, that may well be able to mediate certain domains of visual recovery with training. So it's important to look at it. And then, and obviously LGN and MT and pulvinar MT we're interested in because both of them have been described in residual vision or blind sight investigations in the past. And so also, as I've discussed before, may have a role in restoration of vision after a brain injury. And So we've taken changes here in behaviour for each of the different measures that we obtained. So we have the clinical perimetry, which is the Humphrey change, specifically interested in the area that was targeted by training. We also looked at how the ability to detect moving dots changed with training, and the ability to discriminate direction of movement. And obviously we were interested also in how the contrast detection task showed changes, but perhaps to a lesser extent in this particular cohort of patients, because we only had 7 participants, and of those 2 were already at ceiling when they were performing the contrast detection task at baseline. So that was going to limit the benefits of kind of any correlation analyses. And so what we wanted to look at basically was which baseline measures were most highly associated with change in performance for each of these tasks. And potentially would require, we could have like a cutoff for our Spearman rank coefficient of at least 0.5. Bearing in mind, of course, that this is just a pilot study, which will be informing future work where we're going to gather much, and actually have already started gathering much larger data sets. We've in fact just recently closed a study with 20 participants on a very similar protocol, undertaking doctor training with Professor Crystal Huxland's lab in the University of Rochester. So looking at visual field perimetry first of all, we found that this was most highly correlated with baseline MT, so visual evoked signal in MT in the damaged hemisphere, so when images were shown to the blind field. But also there was a significant correlation with baseline fractional anisotropy in the LGN-MT tract in the damaged hemisphere. We also found that there was a weaker association with fMRI connectivity between MT and the intact hemisphere. And then looking at moving dot detection, we found with that the best predictor of change was baseline fMRI connectivity between LGN and MT. And then for moving dot direction discrimination, so that was very highly correlated with, or inversely correlated rather, with lesion size. But we also found a significant association with baseline LGN-MT fMRI connectivity, and to a lesser extent baseline LGN and V1 fMRI connectivity. So this is just a small pilot study, as I mentioned. It's really just a hint in terms of the results so far as to what we may expect to find in a much larger data set. And taken together, this body of work, it suggests that training-induced visual changes might be predicted by the presence or absence of preserved neural structures that bypass the primary visual pathway and can be measured using structural, diffusion, and functional neuroimaging modalities. And in the future, we may be able to guide and select treatments according to the presence or absence of these preserved structures in individuals. So I'd like to thank all of these individuals for helping me complete the work which I've presented today, and I'd like to thank all of the patients who participated in these studies. Thank you.